items. But welcome to our May edition. I can't believe it's already May of our Montana Antimicrobial Stewardship Coalition call. Thank you all for joining, and thank you to those that do have their webcams on. It's always really nice to see you guys. So today we have Dr. Koo presenting on antimicrobial stewardship. So we're actually going to do more of a didactic lecture today. But I did want to just throw out there, if anyone has had anything interesting lately or anything that you would like to share, any problems that you guys have been experiencing out in your facility, if you can just contact me or Vince Colucci. And if you're interested in presenting, we would really love to continue to hear from our facilities and have case studies be shared. So any critical access hospitals on the call today, we'd love to hear from you guys and things that you guys are currently experiencing. So just keep us in the loop and just feel free to reach out to us. We may reach out to you. I know I've worked with a couple of you related to some interesting things lately. So just kind of wanted to put that plug out there. Vince, did you have any housekeeping items you wanted to review with the group before I turn it over to Dr. Koo? Oh, you're on mute.
Not really. Thanks, Erica, but I will reiterate what you said. As the year rolls on, I'm going to be maybe coming out there and asking or recruiting, because I know you all have some interesting stuff out there for stewardship issues, cases, problems that if you're sharing it, someone else has seen it. So we want to know about it, number one. Two, we love participation. Three, if we have an agenda, obviously, but if there's something that you want to know about, want us to repeat, or want us to talk about, throw that out so that we can then kind of search and work on that as well, too.
Perfect. Thanks, Vince. All right, Dr. Koo, are you able to get the slides?
Yes, but actually, just to add to the some of the housekeeping things, I just also want to touch base and about something that I brought up a couple of times in our previous sessions about looking at some other sites where you can get some educational information on developing your antibiotic stewardship program. And as I mentioned, I'm a member of SHAES. It's a Society of Healthcare Epidemiology America, and they have and I'm actually on their committee for antibiotic stewardship. So they are providing educational information for stewardship. So it's a great resource for you to look up things at just at your leisure, for things that about specific things about antibiotic stewardship programs and what you can include. There's also a couple of tidbits and I have to find the link to that, where they post a little YouTube videos on just a little tips on what you can do with your stewardship program to kind of enhance it, depending on some of the situations. And I know we have in the past talked about urinalyses and how do you kind of get nudge your clinicians into ordering them appropriately, things like that. So a great place site to check out some resources. Infectious Disease Societies of America also has some information, IDSA, on antibiotic stewardship as well. So they're more on the clinical side. So yeah, but I think that's also have some great resources that you can that can help with some of your efforts. So with that, I am going to go and then let me make sure this. Now let's see if this will work. I'm going to share this, and I'm going to make this present. There you go. I'm assuming everybody can see that.
Yep.
So after last few sessions, we're talking about cases. Kind of wanted to go back to a few of the things that we had planned to discuss on things on the syllabus. And unfortunately, this is not one of the sexiest things to talk about, but it's a very necessary thing because this is kind of the way that how many antibiotic stewardship programs will be able to demonstrate some of their successes and their progress in what they are trying to at least in trying to reach whatever goals you have established. And this is actually kind of also a little bit is also important because how you prepare these reports can have a significant impact on how you're going to influence your executives on if you're kind of requesting for more resources, funding, things like that. So they want to be able to see a return of investment. So this is kind of getting familiar with how you're going to prepare your reporting is going to be very important. Now, with that being said, there is no set way of doing it, so to speak. Now, there are, and many programs opt to kind of mirror what they do when they're with their reporting for NHSN, and so it's they'll kind of collect a lot of what they did there, and then kind of impose, and then use the same kind of graphs per se to kind of demonstrate some of the success and what progress they're making with the program. But keep in mind, most of our executives are even though some of them may be clinicians, they have you have to digest a lot of this information for them to understand what that really means. Certainly, if you can translate these some of the your success into dollar figures, that certainly will kind of help with them understanding what your intervention is doing. But a lot of times it's really kind of difficult. So you have to kind of look at other proxies in the sense of how you're going to really demonstrate the effect of your stewardship program, so that that they can understand a lot better. And then obviously that if they feel that this is something that would be worth investing, certainly that would be very important for your program. So just to start, what are the purposes of reporting? And kind of keep in mind, primarily we do some of the reporting to show the status of our stewardship programs, where we are in relation to the goals that we're trying to accomplish, right? And just like the with infection prevention and control programs, where you want an annual goals, you kind of want to have the same thing for your antibiotic stewardship program. So you want to show where you are in that sense. But again, as I mentioned, there is no to say there are no great, well-established, so to speak, way of demonstrating that. So you'll have to look at again, proxies, and I'll talk a little bit about that. And so status of your program, status of your projects, where you are in that sense. Certainly, again, I mentioned NHSN, submitting data to them for accreditation purposes also is very important. And so, and depending on what agency you use, whether it's the Joint Commission versus DNV, certainly a lot of times they mimic what NHSN would ask for. So you have those reasons that you'll make sure that you have those reports readily available. And finally, as I pointed out earlier, is that you want to be able to make plead your case for when you request funding or resources for your stewardship programs. Now, what do you report? And that's, as I said, there are some things that you can really mention, but yeah, you have to also digest it. So, Jenner had a while back had mentioned about discussion how to calculate the annual DOTs, or use the annual use of antimicrobial agents. And so, certainly that kind of plays a factor, especially if you can use that information and then translate that into the costs. And certainly that's commonly what it's used for in a lot of ways, to see, initially is how much, a facility, how much antibiotics is being, antimicrobial agents are being used in a facility, and then translate that into dollar figures. And usually that's kind of become a percentage of the total annual pharmacy expenditures. So, and for a lot of facilities, antimicrobial use is really, it takes a huge chunk of the use of, the expenditures by pharmacies. NHSN have also requested, have been collecting data for the standardized antimicrobial administration rates, the SARS. And again, it's very similar in this concept of the SIRS, the standardized infection rate for infection prevention and such. It's just that, that what it does is compare, it's a measure of comparing a facility, the use of the antimicrobial agents in one facility to others. So, and now, outside of NHSN, I haven't personally found anyone kind of talk about using this as anything to help with their program in that sense of, adjustments. So, from a practical standpoint, the SARS isn't really helpful, and for those on the running the programs. It's mostly for the for NHSN to collect this data to kind of compare what everyone else is doing. Now, certainly, it could you can use it as an indicator if you're much higher than what everybody else is doing. That and you're seeing it could kind of give you an indication of what things what your clinicians are doing. But there are other indicators that you can kind of use to kind of really determine that, is there, is antimicrobial use, is it going to, how much of that is impacting all the other metrics. Now, one thing about the SARS is it doesn't differentiate between appropriate and inappropriate use. So again, there are some limitations to that. Others are is that, as from the DOT is that converting into dollar figures, how much antibiotics are being used and what's the cost of that. You can also break it down into different class use where you can, whether it's inpatient or versus outpatient. But and then what most of your facilities should be using also is reporting the antibiograms, and that's actually a good proxy of how antibiotics are being used in your facility. Primarily looking at resistance patterns, things like that. Other things that you could consider also reporting, included in your report for your stewardship, is incidents of hospital-acquired infections, such as C. difficile infections. There, you could also include adverse events associated with the use of antimicrobials. So these are kind of other things that you can kind of add to a report, your annual report to your executives, or to depending on which if your program is reporting to a PNT committee or to an infection prevention committee, but just to kind of see where you are in relative to your goals and your accomplishments. Now, as I mentioned, executives are probably one of the more common ones. I just use that as an example, mainly because of we usually present that for quality measures as well as for requests for fundings. But others are like others that you can report to are to the PNT committees, certainly to clinicians. Again, you have to tailor some of these graphs reporting to that specific population, as well as to the nursing staff. Again, you tailor it in the context of what your goals are. Or what is your goals, and with that targeted population. So if you're looking at trying to encourage clinicians to improve their use, you want to use the data and present the data that will help kind of accomplish those goals. So and some of those, and that's actually one of the strategies that has been proposed is really compiling these little report cards for the individual, either to the department, various departments, like to a group of surgeons or the individual clinicians, and in relative to how they're using the antibiotics to compare to the their other peer clinicians. Now, so the next series of graphs is just a few things that just from that I put together. These are really graphs from Billings Clinic, and just to kind of show you what we show in our annual reports. So this is a graph to just demonstrate the antimicrobial days of therapy based on comparing them to each year. 2020 was actually pretty good high use of, and I believe 2021 is actually even higher, mainly because of the use of remdesivir. Now, I said this doesn't differentiate the different types of antimicrobial agents to use, but again, this is just to give a more general overview of the use of the antimicrobial agents over time for each facility. You can certainly break down antibiotic into different things, graphs usage. So here we are broken down to different antibiotics, azithromycin, some of the quinolones, ceftriaxones, and such, and compared to over time. Just to point out here is that our use of because of our use of ceftriaxone went up as we have impose more restrictions the use of quinolone. So as you can see, that ceftriaxone went up as quinolone use went down. So and again, this is part of an intervention that we have employed. So certainly we can demonstrate here the the effect of any intervention that was imposed, and it looks like it's probably occurred around 2014. So the cost is another thing. Again, this is something you would like to present to your executives, and also should demonstrate how the cost of per day per patient day. And as I mentioned, in 2020, we had a really high cost. A lot of that was because of remdesivir. And here we have also broken it down to 2020 without remdesivir, and you can see that it's actually we did better with with antibiotic use. So most of our antibiotics, antimicrobial use was really directed toward the remdesivir. And here's it's a couple of graphs. You're just looking at expenditures based here about fraction of the total expenditure of a hospital. What we use here in for the total pharmacy costs. You can also look at the use based on, again, absolute numbers of percent based on per year. And here on, again, 2020, remdesivir really took the brunt of the cost of our of the antimicrobial agents in 2020. Other things that you can look at is again, breaking down onto other metrics. See if you want, this is really kind of presenting to more P&T and such. But here is actually is a graph showing how our antimicrobial stewardship intervention, how that resulted in cost savings. So as you can see, this is broken down into, try to intervene for double, to eliminate double antibiotic use. And obviously that those are by the column of cost avoidance per intervention shows that for every intervention is $150, and overall with 18 interventions we have saved for $2,700 for that particular intervention. So certainly for you could this is something that you could show, again, breaking down all the different projects and all interventions you have employed for your facilities and how effective they are in the overall costs. Now, the other part is that we can look at a proxy of looking at how effective your interventions can be is looking at the resistance panels. And as I mentioned earlier, the antibiogram is probably one of the more common ways of doing that. As you could see that, you can juxtapose which antibiotics are commonly used, and you can look at what's the susceptibility of those antibiotics over time. So here is a susceptibility profile of E. coli for over 13-year period, and we've we have noticed that early on when quinolones are still fairly have been very commonly used, that the susceptibility has gone down. Now we haven't really restricted that much in the outpatient settings of the quinolone, so the effect of this may not have really effect of just inpatient really haven't translated into improvement in the susceptibility of E. coli in this graph. But this is, again, if you could certainly show, you can demonstrate the effect of an intervention, or what is the or some of the consequences of continuing use of certain specific antibodies using these type of graphs. Here's a graph on Enterobacter. As you can see, I mentioned earlier, is that we have increased the use of ceftriaxone. As you can see here, the susceptibility of ceftriaxone to the Enterobacter being susceptible to ceftriaxone has actually trended downwards because of the increased use. So this is a way to kind of show that the results of some of the antibiotic use. Certainly, we are also can look at a case. Here is just all the ESBL producing organisms and where they're occurring. And we're seeing many more of the ESBL cases of ESBL producing organisms from a community-acquired setting, and a lot of that is a reflective of the antibiotic use in that setting. We don't have as a stringent of an antimicrobial stewardship in outpatient setting as we compare to the inpatient setting. So this is kind of reflective of that the deficiency we have here at Billings Clinic, which I'm hoping to work on in the near future. Looking at other susceptibility, this is kind of useful just to kind of show the use compared to susceptibility of specific organisms. And then finally, can also look at because antibiotic use is a major risk factor for C. difficile infections. Using the C. difficile SIRS can also kind of help use as a proxy to determining the effectiveness of antibiotic use as well as the effectiveness of your antibiotic stewardship interventions. So, and just to kind of finish up real quick is that remember that there are a lot of different things that you can present. There are some things that are more specific, but they're more applicable to reporting to certain certain target audiences. So you do want to kind of bear in mind that as you're as you're preparing reports, be mindful of to whom you're presenting these, so that and design your presentation that way, so that you can achieve your goal, whatever goal that it may be. And then certainly be aware of your audience. I mean, many of them, as I pointed out, like executives don't really have the clinical background. So to make the art, you have to really translate a lot of what you're trying to accomplish into terms that they would understand. And then finally is that you really want, there's a lot of data. We do this, we collect a whole lot of data for antibiotic stewardship. A mini stewardship program will do that. So we have to simplify and digest much of that data so that they're, usable and and then comprehensible to your target audience. And that's all I have. So this is just a really quick, brief overview of things. I know this didn't go really into the details about some of the how exactly the step-by-step. So but if you do have any questions, please and you can ask them now, or feel free to reach out to me. But just kind of keep in mind is that there is no one set way of doing it. It's really kind of, you have to kind of really present your data in a way that whoever you're presenting to, it will and whatever goal you're trying to accomplish, so that it's applicable to that. So, and that's all I have.
Well, thank you, Dr. Q. That was really interesting. I really enjoyed that. I think it resonated a lot with the deliverables that we ask in our Montana AMS program. And I think kind of helps to give some background as to why we ask for the data that we ask for. So for example, you touched on days of therapy as well as antibiograms. And so related to the days of therapy, Jenner is still collecting monthly days of therapy that can be submitted, 2 different ways. Here in Montana, we did create a days of therapy tracking tool for you guys to use that you can submit that data. You can enter that data into and then track your days of therapy that way and share that data with your AMS team. We also have the AUR option, which is the antimicrobial use and resistance module in NHSN itself. And I just wanted to give everyone a heads up. We are hoping to provide some financial support for the access to the AU module in NHSN. So more news will be coming out on that. And we do utilize that data. Jenner does look at that data. We are hoping to get some data reports put together and shared with the facilities that have been participating in the Montana AMS program. So just stay tuned for that. She is working on that. And then the other thing is the antibiogram. I know I've gotten a lot of requests for antibiograms lately. We do post antibiograms that facilities give us permission to post on our Montana HAI webpage. Jenner's also working on getting that updated so we can submit the 2020 and 2021 antibiogram data. However, as a heads up, a lot of our PPS hospitals are not participating in our Montana AMS program, so we did not receive an antibiogram from a lot of our large facilities. So if you are from a large facility and you're willing to share that with us and willing for us to post that on our webpage, we would greatly appreciate that, just because a lot of the critical access hospitals use the larger hospital data for their own internal antibiograms. And then just kind of a reminder, you may want to look at, if you're situated in a facility and you might be a Billings Clinic affiliate or something like that, but you're located closer to another larger PPS hospital. That's why we're hoping to post all those so you can kind of see geographically where you're located versus, also who kind of you guys are related to for your facility type. So just a couple of things I wanted to throw out there, with our program and why we're doing what we're doing. Vince, did you have anything? You look like you wanted to chit chat.
Of course. I'm, as many of you know, I'm from Anaconda, so I never pass an open mic or an open bar up. So it's like, Dr. Kook, excellent job as usual in giving us some information. Erica, just to follow up with regards to the antibiograms, a couple of years ago, I was talking with Dr. Jeff Jansen at St. Vincent's, and he gave a presentation to the pharmacy group with regards to antibiograms and how can we create kind of like a state antibiogram. And so we've been kind of playing with that idea and getting all those data into one pool so that everyone could access it. And I think we can kind of circle back to that. And I think if that's, I don't know if Jeff's on today, but we can talk to him about rehatching or bringing that idea back in, kind of coming full circle with it so that everyone has access to it, or those that want those data have access to it. Just if not for overall educational purposes, for comparative purposes, and see if there's trends that we're seeing in different parts of the state that carry over. So I think that's actually a pretty good source. But I'll when you were talking about that kind of, I thought about that. I got a couple of questions maybe that you can address. So with the critical access hospitals, obviously we all know that the resources are stretched thin, and we're kind of stretched thin everywhere. What's the reporting structure, or when antimicrobial stewardship first became got some front page headlines there, we were able to get some resources nationally behind it and some push behind it. One of the requirements was to form an antimicrobial stewardship committee within your own hospital. And again, some of the hospitals have everybody's resources are stretched. if you weren't able to pull that, and you're asking people to put on another hat to sit on another committee or get that how would you suggest, or what would be the easiest way for smaller hospitals to do they actually have to form a specific identified committee? Is that the best way to do it? Have you run across anything, and then does Shay have any examples or commentary about trying to get that together with short supplies of resources?
So yeah, that's a part of the reason I actually sit on the the Antimicrobial Stewardship Committee for Shay is to represent the rural areas, because many of the concepts and some of the requirements, so to speak, as well, is really based on facilities like the big academic centers, and they have all the resources to collect this data and to be able to digest it and do everything, and that leaves but and I think that it's easy for them to say that, but and then unfortunately that kind of end up becoming a lot of what CDC has to kind of ingrain into a lot of the, as well as CMS, into some of their elements, and that's without really consideration of what resources most of critical access hospitals have. I mean, you're right. Not everyone have ID docs. I mean, how many we have? What? 12, 15?
About a dozen, yeah.
Yeah, that's about it. I mean, I can tell there are more hospitals than ID docs in Montana. So I think that's one of the biggest challenges is that it's how how do you do that? And so having individual groups it's going to be hard. Now, with that being said, there are business ventures that are looking into this. Intermountain Health has actually offered to do a lot of that. So, and there are pluses and minuses. I mean, the biggest plus is that you get expertise. For that subscription fee, you get expertise readily available to you. But they're not on site. So any intervention or consideration you have for that specific to your site, you have to come up with the solution to. Because they can offer a recommendation in a general concept, but they don't have their boots on the ground since it's actually there to do the thing. So they can only they can do some of the things, like they can collect your data, help you collect all the data, do all the reporting, things like that. But as far as they could also suggest what interventions, but you're kind of on your own, I believe, on the most part, unless it's just like any telemedicine, is that you kind of still have to that implementation part, but you still have to go and talk to all the individual clinicians and get their buy-ins and things like that. So that's a challenge, and I think that's and that's if you have the appropriate people. So going back to what you were asking, do you have how do we address this? This is something that we brought up. They're trying to figure out how to best address and make it not either acceptable to have a shared shared governance, so to speak, with and one ID doc over and one ID doc, the pharmacist overseeing several hospitals. I think these are some of the things that they're trying to being looked at to kind of help out. So more to come, and no great solutions. They keep making more regulations and more requirements. They're not coming up with really good solutions. How does it this is going to work for many people? Yeah. So anyway,
yeah. Good, thank you. Yeah, I know it's a tough question. I didn't want to mean to put you on the spot like that, but I think it's something that probably a lot of folks are dealing with, and just to kind of share those thoughts a little bit. I appreciate that. Then one other question I had, or comment, or area that I'd like you to comment on. Erica and I were talking the other day about moving more, or adding, I guess, annexing the outpatient component along with the inpatient component. And so what would you suggest to be the first step in doing that, if you were going to try to include say ambulatory clinics that are associated with a small hospital with regards to AMS services? is there an area that you would suggest to kind of initiate that, or how would you jump into that?
Yeah, that's a good question, and I think that well, I'm trying to not think of what bigger institutions would do, even
Yeah.
Billings Clinic for that matter.
Right.
I think that one, I think probably the big first step is to figure out what's the prescribing habits of your clinicians. I mean, but that's going to go for everything, right? You want to know what your clinicians are actually really doing.
Yeah.
And you know the problem. You just have to see what's contributing to the problem. So knowing that, so and sometimes it's easier, and that, again, going back to the reporting, what I mentioned earlier is you can, if you can collect data on their prescribing habits, you can also show it to them and compare it to their peers. And so this reports, reporting, having a report card, so to speak, to compare to their peers on how they're using. Now, and you can correlate that with the number, and this, you could go a lot of different ways in this, whether you can see how many patients that you have you have put on antibiotics because of XYZ things. Now, with that being said, it is a lot of work too, right? I mean, it's not something you can just snap your finger and then this is going to happen real quick. So you gotta, you gotta have the personnel. And this is actually why it's such a challenge to implement any of these programs, because it's not so much as something that's easily just you can kind of turn on and you can make it happen. So report cards are great if you have the resources. That's not just, and we're not just talking about pharmacists, but even softwares. And that's one thing we're trying to deal with here a little bit, is finding the right software to data mine, to collect all the data, right, to compile these reports. And but once you can do that, it is very helpful, because most clinicians are oblivious of how much prescribing, antibiotic prescribing they do. Because a lot, it's kind of well, gosh, what a description. It's kind of like, having a puppy and you're training them to go potty outside, and then, but you're trying to school, they only kind of remember, once it's out of their body, they don't remember it. So once, and most physicians, like when they write their prescription for antibiotics, they don't kind of forget about what happened. So if you ask them how many antibiotic prescription you wrote today and on a given day, they probably won't remember. So that's the problem, is that a lot of them don't. So doing it this way may kind of help remind them, say, oh, I didn't realize that I wrote that much. And then to say, are they really appropriate? That's the key word. And many of them we're going to kind of, and you have to add that component of, is this really appropriate? Are they writing this because there is a patient with a bona fide infection, or they're doing this in response to a lab result, which is very common, right? We see that quite often. Or the patient who comes in because you're doing it mainly because they're a patient who come in with some sniffles and demanding for antibiotics, is that, so I think that those are the kind of things those are the things that more on the outpatient that we kind of have been explored to, at least as an intervention. Again, it's a totally different ball of wax compared to inpatient, because of the fact that in inpatient, most of us can control what clinicians do. Outpatient's much more difficult, because of the fact that you can't, they write a prescription, they can go to any pharmacy. So you can't even get pharmacists to intervene. Now, some outpatient pharmacists can help with that, but for the most part, it's a lot more challenging.
And especially, you made a good point in terms of like how much of it is based on information that they have, or how much of it is empiric, and just a gut feel. And it's like, well, I'm going to write this prescription for an upper respiratory tract infection, and I want to cover Pseudomonas and H flu and Marexel all in one shot, rather than zeroing in and was it actually a pneumococcus that I was treating, and you don't have that information, but they got better. It's like, okay, so it worked, so I'm gonna do that. Right. You don't even know if it was correct. So yeah. But okay, some good ideas. Thank you very much.
We do have some questions, comments in the chat. So the first question, what are the best options for projects and committees for critical access hospitals? And in response to that, Holly from one of our critical access hospitals said, what we do at our critical access hospital is the AMS board is looped into the IP board, which is connected to the medical staff. So any staff sitting on the medical staff are part of the IP AMS board. And then another kind of question comment, Dr. Q, have any critical access hospitals asked you to sit on their AMS committee? We currently don't have one, but we do have a physician family practice on our committee. We also have present all protocols to our medical staff. And when she says we don't have one, she meant an ID physician.
So as I mentioned, one of the challenges, and I believe it probably will become a requirement, at least I'm hearing some rumors about that, is that it's not just going to be a physician champion, but a physician champion with expertise. So, and the same thing with pharmacy. The pharmacy champion will have to have expertise in antibiotic stewardship. So, so to answer the kind of question, I have not been formally asked. I've been contracted through Billings Clinic to sit on the antibiotic stewardship program for I believe for CMC in Missoula. I think that we are kind of talking about, at least for the Billings Clinic regional, our affiliates and partners, to set up a system where we will have a more integrative antibiotic stewardship program where we'll have oversight governance on the different sites. Now, for those who are not part of our system, that's going to be the challenge, because I think that and we may have that is a big challenge, because and that's something that is something that we do need how to address. And most of places will either choose to have, if they have a local ID doc, they can do that, or do something like a telemedicine through Intermountain, which is what they're offering or such. I'm not sure if again. So I wish I have a good answer for you. No, I don't, other than the CMC, but I don't really sit in other sites unless they're a part of the Billings Clinic network. So, and then I think this is why Erica and Vince and I are doing this, is because we know that there is a need. We need to develop programs, but we don't have all their that not many of the sites don't have the expertise to do that. So we're trying to kind of fill in a little bit of that void, but we can only do so much here. That's the challenge. We can tell you what to do, but we don't have people there to actually do it for you.
Yeah, and we are hoping to kind of expand on the pharmacy services that Jenna currently provides. We are hoping to be able to add in a couple more critical access hospitals related to your days of therapy, prospective audit and feedback. So if you do need help with your days of therapy, please do reach out to me or Jenna. The other thing is this is something we review when we do our free, non-regulatory infection control assessments on site with your healthcare facilities. We can review antimicrobial stewardship, your programs with you. Because AMS is kind of the second part of our IP team, so kind of Jenna and myself and Vince, we would just need a heads up that you wanted to talk about your AMS program, and that's definitely something then when the IPs are on site, they can kind of work with us to schedule a time for us to call in and assist you with your AMS review. So just some things to be aware of for resources that we are offering. And then we did have a couple more questions, comments. So Colleen would like to know more about outpatient clinic antimicrobial stewardship strategies. So I would say hold tight. I think like Vince mentioned, we're going to have more information coming out with that. We have kind of a 2-year plan for the program and then a 5-year plan for the program. And definitely within the next couple of years, we'd like to start doing some more on that. And then we have another comment. I think that any CAW facility would need to justify via financial and outcomes what the AMS program can do for the facility, patients, and providers. I don't think a report card, which can be seen as a negative, would convince implementation in regards to implementation in our ambulatory setting.
And if I might, Holly, I understand that. And I think that and that's why I keep emphasizing, you have to kind of know what drives your clinicians. But the antimicrobial stewardship program for every, there's no rubber stamp. It's not a cookie cutter kind of form. You have to kind of really tailor your program to your site based on your clinicians and however, and executives and such. So the report card has been brought up as a suggestion, has worked for some sites, some facilities, but not every. So if it doesn't work, we'll think of something else. It's just the challenge with outpatient is a lot of that the restrictions are not there unless you're a closed system. Let's say, for example, you work for Kaiser, Kaiser Permanente, where they have a closed system that that prescribing has to go and the prescriptions has to go through their pharmacies. You can control that. But if they're going, they can go to any, someone writes a prescription and can go to anywhere, then that makes it a little challenging, but you can't restrict the antibiotics. So you have to find other ways to nudge your clinicians. Now, one of the things we do here that somewhat helps is that that app that I had mentioned, it was called Spectrum, now it's called First Line, but and that app is, if you're hoping is that they will look up the prescribing recommendations on that app, and that will help guide some of the stuff, whether it's the antibiotics, if it's appropriate, or even the workup in general. Others are going to other things that can help nudge your clinician is, and this is what I'm actually one of the things I'm working on a paper on is diagnostic stewardship. How what leads to that decision to prescribe. Why and that's and that's actually applicable to both outpatient and inpatient setting. Whether and probably the most common is UAs, right? UAs get ordered for almost a bunch of things, almost everything, and it partly is because of the ease of use, and as well as but also there's a lot of other it's also ordered for a lot of other reasons. The problem with UAs is that no one really restricts what's being reported, and that's part of the challenge about if you're ordering it because someone's ordering it because they're looking for proteinuria, but then they get and in addition to the protein level, they also reports the nitrates and glucoside esterase. Clinicians going to respond to those abnormal results because they're just kind of tuned to that. So again, so we have to kind of find out how do we nudge our clinicians, whether we limit or make specific types of urine studies for in particular indications, or limit the reporting of those to the indications that may help nudge the clinician into, or hopefully convince the clinician that they don't need to treat something that's not what they're looking for. So there are a lot of different strategies. You just have to figure out. That's the hard part, is figure out what makes your docs tick.
Can I interject just for 1 second? So when I'm looking at, because I would love to get into our ambulatory unit and work more with the providers, but I think the big holdup in cause is the financial part of it. And I think if your 2-year and 5-year plan can look at how this program can be connected to the CMS requirements and reimbursement, I think you'll make some headway in it. But it has to be connected financially, because you're looking at, my position is right now part-time. And so they would look at, I would have to go up to a full-time just to cover that workload. And so I think if you're looking at trying to really expand into ambulatory settings, you have to connect it to something that will make sense to our administration to justify doing that. So on the 2-year and 5-year plan, that's what I would say. I would love to do it. I don't know that we could, I don't know that our little facility could afford to do it right now, but on your plan.
That's a great point, Holly. I agree 100%. I would just maybe comment in this vein and maybe addend to what Dr. Koo had said. A lot of the work with AMS programs, antibiotic stewardship programs, and antimicrobial stewardship programs were forwarded and based on cost avoidance and doing all that work up front. So we know that it saves money. We know that it can create a significant portions of savings that can then be shifted over towards human resources and so on and so forth to complete and to continue to do these programs. That's there. Having said that, every place is different, and you have to get into each place and find out where you can and how you can save in each place. But those are there. So within any plan that we develop going forward, that would be an essential component that we would put in that plan, so that it's at the same time it's going to generate, or hopefully generate, some sort of cost savings. Now, is that going to be upfront? Maybe not, but I mean, there's got to be some trust that we're doing this to improve the outcomes in a favorable manner, both clinically and financially. So, but it's going to be a put up or shut up type of a deal, and that's kind of what our intent is. Absolutely. And each, I wouldn't. My experience has never been to bluntly throw out a report card and blindside somebody. That nobody likes that, right? It's like, hey, here's your report card. You haven't been doing scrap, and we're gonna nail you. Everything has to be kind of done up front. We're not going to circumvent or do a shadow program and then blindside anybody. It's with buy-in up front, and it's with physician and clinician champions that we can get some collaboration, go into it. And then you're always going to have a couple of people that are, take things personally, or they're outliers, or and so on and so forth. And I look at that two ways. Number one, we can get them on board because we can give them the information and say, okay, here's what we're doing. Can you do this better? Or can the whole system do this better? We're here to help you. Here's the resources. Secondly, I mean, let's face it, there are some bad prescribers and utilizers of the system throughout. And so sometimes it has to be uncovered. And you will take some shots occasionally. We're not intending anyone to go out and do that and be the bad guy and so on and so forth. But I think if done in the right way, it can really demonstrate some good leadership and some good forward moving parts that eventually, in retrospect, my experience has been everybody looks at it as a good program going forward. So we're going to try to do, we're not going to say we're not going to make any mistakes, but we're going to try to do it in a way that incorporates a lot of what, your concerns are, for sure.
And just to kind of follow Holly, I mean, here one of the main purpose for this webinar, series is to help us to tailor a lot of the requirements that's being imposed, onto all the hospitals, and make it more usable for smaller facilities, critical access hospital and such. But as I pointed out, many of these concepts are based on a lot of those requirements of they kind of had bigger hospitals in mind, and so they could do a lot of stuff. We can't. I could still, even us at Billings Clinic, we have some significant limitations, because of other things. And now, so they're going to be. So, we're here to kind of talk, share ideas amongst each other. I will try to bring in what I hear from Shay and other organizations to kind of see what what's been tried and what we can do to kind of help with some of these challenges that we're going to encounter. But unfortunately, I would like to say that things will stay static and give us time to catch up, but there are some proposed new proposal in that being considered right now about reporting and such, and so there's so it's gonna kind of it's just gonna get really challenging, and so my hope is that we'll all work together to kind of hopefully we'll help each other to get to do what to meet those requirements. Any other questions?
Oh, great comments on you guys. Thank you very much.
As I said, this is not very sexy topic, but it's very necessary because because everything is kind of, that's how they know what we're doing on that. But there's some set ways, others are not. You kind of have to kind of really I don't want to say manipulate, but you have to present these data to whatever you want to accomplish. And that's the hard part is, that's the biggest challenge is to figure out how do we, what do we need to present to convince or do what we need to do. So, and it's just, but I think that, that hopefully I gave you an idea of how to accomplish that. And again, feel free to reach out to me. I'll try my best to answer your questions. If you want to have a, how do you present the best way to present to do something? I'll try my best to offer some good solutions.
Thanks, Dr. Koo. So I feel like these webinars always fly by. So another one that flew by for us. It is about time. So any final questions or comments, just a friendly reminder, our next MASC call will be on Wednesday, June 1st from 11 a.m. to noon. If you haven't had an infection control assessment performed by the Montana HAI program in the last year, we'd be more than happy to come see you. So just let us know if you're interested in that. And then in the meantime, like Dr. Koo said, we are available if you guys have any questions related to antimicrobial stewardship or would need any assistance or anything like that, please do feel free to reach out to us. So we will see you next month. Thank you as always for joining us, and it was good to see you guys again. Bye, y'all.